with the second wave, which is, it's starting to subside but not go away. All the data are that there are fewer cases, but we've still got good numbers of cases. We've taken a very different approach in the National Health Service. We were, although many hospitals were quite full of COVID patients, in our hospital we had 100 inpatients with COVID. What we've done is we've continued with our activity in hematologic cancers. We haven't deferred therapy, we haven't deferred transplants, and we haven't deferred CAR T-cell therapy, even though those patients sometimes need the intensive care unit, for which obviously there's some competition. So when a patient has a problem that we are aiming to cure, we haven't altered our therapy. There's been some controversy about what patients undergoing therapy should do with their lives and their attitudes towards the virus. And I think, unfortunately, the government gave quite confusing information about shielding, and it certainly confused some of our patients. And we've taken a quite a conservative view on this and advised our patients to not shield, not stay in their home the whole time, but to be very careful about avoiding contact with new people, to wear masks, to distance, be very careful with hand hygiene, so that they can go outside, they can go to open spaces. That's absolutely fine. They can go to shops provided there's proper distancing, and they wear masks. But to be very careful. And speaking of my hospital, we've had very few patients with hematologic cancers who've had COVID. When a patient does have COVID, they're very tricky to manage. You've got all sorts of decisions. Sometimes you're committed to continue with the chemotherapy, but watch them very carefully. There are advances, that we know very clearly that dexamethasone in patients who are oxygen dependent, that improves their outcome significantly. And although there's controversial data about it, it is my view that remdesivir is an effective drug, and that's something we've certainly given to some of our patients. Of course, the very major development and recent development is the approval of the Pfizer vaccine, the Pfizer-BioNTech vaccine, which is an mRNA vaccine, and that there will be other vaccines almost certainly approved. The Moderna vaccine has similar efficacy, and we also have the Oxford AstraZeneca vaccine, which is slightly harder to evaluate. I think we may need some more data before we work out the optimum way of giving that vaccine. But essentially, many of our patients will need to be vaccinated. It's not a straightforward business because some of them do not have normal immune systems, and we're a little uncertain about how well they'll respond to the virus, to the vaccine. But it's going to be a policy for most of them to vaccinate them, and hopefully will offer them at least partial protection. Of course, the other thing that will protect our patients is if everybody else gets vaccinated, which is something I think we're all very much encouraging people to do. If we all do our bit, then we can crush the virus. So those are and that offers real hope for patients, because we don't, it's bad enough to have a blood cancer, but also having to lock yourself away. That's the time where you really do need people around you. You need your friends, you need your family, and you need physical contact and all those things. Well, none of us have done any of that over the last few months. So I think that those, it's going to take some time to emerge from this. We're going to need to vaccinate a lot of the population before the quality of life of our patients improves. I think during the first wave, probably particularly between about April and maybe the end of June, we did see a reduction in numbers of patients. There was certainly less patients diagnosed with ALL, and we also did do fewer transplants, and because there were fewer new diagnoses, and there were some patients who declined a transplant during that period of time. They were worried about being immune suppressed after transplant and not being able to cope with the virus. And then, so really since about July, we've been extremely busy. The trial I mentioned called ALL-RIC. Well, since sort of that trial was suspended for 3 months because research personnel were working on COVID-related studies. But since reopening, I've put 5 patients on that study. It was really busy, and we've just had huge numbers of new ALL patients. So yes, I think that there were some patients with sort of low white cell count ALL who did probably would have been unwell, but not very unwell, who just didn't come to hospital. And of course, those patients have now been diagnosed. I think the people with very advanced disease, they were so ill, they just had to present to hospital. But it has been a very strange year in terms of we've been busy, then there's been a lull, then we're extremely busy again. And we're going to be busy right through December and Christmas, where we're doing lots of transplants in December.